Our first speaker is Professor Orla Morrissey from the Department of Infectious Diseases at the Alfred Hospital. And Professor Morrissey is the lead clinician at the immunocompromised host consult service there for Alfred Health. And she's a clinician scientist, and she's done a lot of work in fungal disease epidemiology. She's been on a number of national and international guidelines, including the Australian New Zealand Mycosis Interest Group, as well as she's currently co-chair of the IDSA update, the guidelines of aspergillosis, and is associate editor of a number of journals on transplantation and infectious disease. So I'd like to welcome Professor Morrissey to speak to us today on invasive fungal infection in lung transplants. Thanks, Orla.
Thank you very much for that kind introduction, Andrew. And it's great to be the first presenter at this inaugural meeting. And I really thank the committee for inviting me to speak. It's been really a great honour. So as you can see, I'm going to talk about invasive fungal infections in lung transplantation patients. These are my financial disclosures, and all funds are paid directly to my institution. So lung transplantation is done to prolong life and improve its quality in those patients with end-stage lung disease. While our short-term survivals are fantastic, over 95%, long-term survival is not as good. And if you can see here that compared to heart transplantation, sort of the median survival after 1 year is much lower than for heart transplantation. And it's really down to infection and chronic lung allograft dysfunction that are the biggest challenges to trying to improve long-term survival of lung transplantation. And the two of them interact, in other words, that infection can precipitate chronic rejection, and vice versa. Treatment of chronic rejection can make opportunistic infections worse, etc. So while we spend a lot of time on bacterial infections, we spend a lot of time on viral infections such as CMV. It's really the ones that don't pop up very often, the fungal infections, are the ones that are associated with most problems in diagnosing treatment and also associated with the highest mortality rate. So they're the things that we really fear the most in lung transplantation. So this is from the TransNet data. TransNet was a US prospective study, which was done looking at a number of US transplant centers. And they looked at transplants and solid organ transplantation patients as well as hematology patients. And so looking at the data from this, you can see that small bowel has greatest number of cumulative incidence of invasive fungal disease, followed very much by lung transplantation, and all the other solid organ transplants tend to fall away very quickly after that. Interestingly, when you look at the different fungi that they actually have, it's very interesting that it's very different for the lung transplantation populations compared to the others. Candida is the big problem for the livers and the hearts and the small bowel, etc. Whereas for the lungs, it really is Aspergillus that actually plays a major role, along with other molds as well. The non-Aspergillus molds as well are predominant factors in lung transplantation. So risk factors are, sort of more generally, the things like the degree of immunosuppression, and the lung transplant patients do get more immunosuppression than the other solid organ transplant population. So they're more immunosuppressed, which makes them more prone to infections. But there are other things as well that make it very unique, particularly that the transplanted lungs are the only solid organ that's transplanted that's in direct exposure to the environment. Also, surgery causes decreased mucociliary clearance, loss of lymphatics, diaphragmatic denervation in some situations as well, and also reduced cough reflex, all of which predispose to fungi getting into the lungs and getting down into the alveoli and causing mischief. There is also in the airway, there's reduced epithelial macrophages and neutrophils as well. So there's increased capacity to get in, and then there's decreased defenses as well. So you can see how easily fungal infections can actually take hold in the lung transplant population. Then more specifically, there are things that are, sort of predominant, such as cystic fibrosis as an underlying disease. So up to 70% of cystic fibrosis patients pre-transplant can have a fungal infection of some sort or isolated fungus, and they're fourfold more likely to get invasive aspergillosis compared to other groups of patients. I'll talk a little bit more about fungal colonization pre-transplant and early post-transplant, but early airway ischemia is a risk factor, and that's particularly for tracheobronchitis, which is a unique disease to lung transplantation, and I'll talk about that a little bit more as well. And then there are other things like single lung transplant, where you've still got a native lung in, which may well be full of fungus, which can actually then just transfer into the new lung that you've actually transplanted as well. So in terms of timing, I'm just going to really look at Aspergillus in particular here, but you can look at the other ones as well. One of the points I really want to make is that we give prophylaxis, and I'll talk about that a little bit more. And while the median time from transplant to the development of invasive aspergillosis is around 3 months, prophylaxis has actually changed that. So it's now actually around 245 days. And that's sort of like just showing you with the arrows here. So just want to talk about some definitions, just for context. So the EORTC criteria are really meant for hematology patients, even though they do actually include some definitions for lung transplantation and other solid organ transplantation. The ISHLT, the International Society for Heart and Lung Transplantation, the ID group, have created sort of lung-specific definitions, and they include colonization and invasive disease. That's how they've kind of divided it up. And I'll talk a little bit more detail about that in the next slide. But really, the difference is that colonization is just presence of the fungus in the airway without any other symptoms or radiological or endobronchial changes. And invasive disease is where you have a marker like an isolation or a galactomannan, etc. And then you've got presence of symptoms, radiological and endobronchial changes as well. And of course, biopsy is how you actually make a proven disease. So sorry, that has actually moved. I'm sorry about that. But really what that box was supposed to encompass was the top 4. So top 4, fungal pneumonia, fungal tracheobronchitis, bronchial anastomotic, fungal infection, and disseminated infection are really invasive fungal disease. And then you've got fungal colonization. And the reason why I carry on about fungal colonization is that because it's most common and it can progress to invasive disease and can precipitate CLAD. While invasive fungal disease is less common, but is associated with a higher mortality. And I think, sort of given that colonization can progress to invasive disease, it's really important to actually recognize it and actually talk about it and know how to manage it as well. So just looking at this graphs is nothing like a Kaplan-Meier to focus the mind. And really, this is looking at patients who have Aspergillus versus patients who don't have Aspergillus. And you can actually see that survival is shorter in patients who actually get Aspergillus at any point in time from their transplant. And then sort of also looking at BOS and the interrelationship between fungus and BOS, which is really a form of CLAD. So you can see that any patient who gets CLAD is much more likely to get, anybody who gets Aspergillus is much more likely to get CLAD further down the field. And as we talked about, CLAD, sort of gets treated with increased immunosuppression, which then causes more infection and so on. And it's associated with reduced survival. So you can see that colonization can really affect the lung transplantation populations. So in terms of incidence, there's been a lot of observational studies done pre-transplant, mostly in the cystic fibrosis population. And, sort of a lot of those are influenced by how frequently you sample and also the timing of the isolation as well in relationship to the transplant. So the more frequently you sample, the more likely you are to get a positive isolate from a cystic fibrosis patient or any other patient as well pre-transplant. And what does an isolate mean if it's done 12 months before the transplant versus just done one month before the transplant? They have looked at explanted lungs to try and have a look at this in greater detail, and they found fungus, particularly invasive disease, in 5% overall, but cystic fibrosis patients is a little bit higher, up to 59%. Then looking at larger studies post-transplant, so the incidence of fungal colonization anytime after transplant is about 30 to 40%. And certainly that's where we sit at the Alfred as well, and Aspergillus does definitely predominate. So just going to talk about prophylaxis, simply because, a lot of time is spent, sort of prophylaxing or preventing colonization, preventing invasive fungal disease, and then, preventing colonization progressing to invasive fungal disease. So there's a universal prophylaxis strategy where everybody gets it from the time they're transplanted for a variable period of time. Most centers use 6 months. Then there's a preemptive approach where you do regular bronchoscopies after transplant. And then once you isolate a fungal pathogen, then you actually give treatment, and it's usually for about 3 months. Around the world, there's about a 65-30% split, sort of between those two, 65% for universal prophylaxis. But in the US, it's predominantly universal prophylaxis that they use for various reasons, including the fact that some areas have endemic fungi as well. And then there's targeted prophylaxis in those patients who are deemed at higher risk, like your cystic fibrosis patients, perhaps your pediatric patients as well. And those patients will go on augmented immunosuppression as well. And some people use a hybrid version, so at variable periods of time, they might start off with universal prophylaxis and then use a preemptive approach further on down the transplant, after the transplantation as well. So there's been systematic reviews done on universal prophylaxis, and one study was done by Shahid Hussain from Toronto, who showed that there was no reduction in colonization or invasive aspergillosis, and a lot of patients actually developed hepatotoxicity following voriconazole. Now we've moved a little bit away from that, but it still shows that this is not without its issues in terms of side effects. There was another study done by a group in Stanford who showed a slightly different, which favoured universal prophylaxis. But if you actually look at the I-squared score, you'll find that it's 76.6% essentially, which means that which is very high and really reflective of the heterogeneous studies that were actually put into this meta-analysis. And it just makes you put a question mark around the actual results of this meta-analysis. Then there's the disadvantages of universal prophylaxis, such as voriconazole, hepatotoxicity. Then there's the unique issue of squamous cell carcinoma that you see with lung transplantation as well. And the longer you go on voriconazole, the greater the risk as well. And people, are fair-skinned, and people on other photosensitivity agents are also at risk of this as well. And it's one of the reasons why lung transplant physicians and ID physicians have moved away from voriconazole. Then there's inhaled conventional amphotericin, which is used in many, many centres. And it's associated with bronchospasm and cough, and also the emergence of resistance. And this is from a Spanish group which use inhaled amphotericin, and they give it to their patients lifelong. Mind you, they give it very infrequently and less frequently as you go along through the transplant, and so that may well be part of why they get resistance. But basically, the resistance has, like they used to be before 2009, 38.1%, and now it's about 58.8% as well. So it does actually have a resistance cost as well, universal prophylaxis. Preemptive antifungal therapy does have proven efficacy, but it also has disadvantages as well, in the sense that you actually need to do the scheduled bronchoscopies after transplant. They need to be regular. You need to have good access to diagnostic tests like galactomannan and therapeutic drug monitoring. And you need to have a good structure for following up the patients. And because bronchoscopies are not necessarily done very frequently, you may well miss the boat. You may well miss the case before it actually becomes invasive as well. So there is that concern with preemptive approach. It's a bit like CMV, the same sort of structural issues that occur with CMV as a preemptive approach. So which strategy is best? Well, it's very unclear. The American Society of Transplantation said that you can use either. And similarly, the International Society for Heart, Lung and Transplantation said the same thing as well. We decided to test this, and for various reasons, this study ended up being done mostly at the Alfred, and they compared universal posaconazole prophylaxis to preemptive therapy. So patients with universal prophylaxis ended up being randomized to start posaconazole between day 4 and 14 post-transplant for longer than 3 months. And those patients with the posaconazole if they were administered it anytime they actually grew or had a galactomannan that was positive on a scheduled bronchoscopy. We looked at a composite endpoint of screened and eligible patients, so a feasibility study, the pragmatic feasibility study, and then we looked at secondary efficacy and safety endpoints. So just some of the preliminary findings from that. We're still analysing the data. It is feasible to do it. Once you get your protocol right. We had a recruitment rate of about 39%, and that was, so that's pretty similar to what most clinical trials can expect as well. We only had 15.3% of patients declined, and most of the other reasons for declining or for not being eligible were logistical issues, such as, going rapidly to transplant after assessment, like within 4 days, or living, interstate as well. However, one of the things we did notice was that they seemed to be significantly less adverse events in those who got the preemptive approach. And those patients who experienced one or more had a trend towards being better for preemptive approach, which is what you'd expect. Efficacy, sort of we're still analysing that, but it looks like, sort of at least preemptive approach is as good as universal prophylaxis. Importantly, 8 of the 17 patients who were on the preemptive arm didn't receive any posaconazole, and we still achieved good outcomes. So it means that you can actually use this approach effectively. I think at the end of the day, my feeling after doing this study is that each centre probably has their own approach. It's going to be very difficult for them to move from that approach to another approach. And perhaps really what we need to be doing is that, sort of some sort of study where, sort of people who use a preemptive approach, centres who use a preemptive approach, look at different antifungals and compare those in a trial, and then those who use a universal approach do the same sort of thing. Really it's more around now, I think, what antifungals you actually use and how you actually use them is probably a little bit more important than which approach you actually use. I think it's really a take-home message for me was, sort of what approach you're used to is probably what you need to end up sticking with. In terms of diagnosis, these patients are much more likely to not have the traditional signs that we see with hematology patients, such as the halo sign and the nodules. As you can see, only about 8% end up in the study having a halo sign versus 56% of those who are neutropenic. They're much more likely to have peribronchial consolidation and central lobar nodules, ground glass opacification. And if they do have nodules, they're often more likely to have more frequent nodules rather than one nodule. In terms of galactomannan, I've talked about this already, but we do use it in the lung transplantation population. It was initially studied in the hematology population, but it's actually being now studied in the lung transplant population very well. So galactomannan is a component of the cell wall, and it's released when there's actually growing hyphae, and it can be detected in several body fluids, and it's an ELISA method. So basically, there are antibodies in the well of the plates that you use in the lab. You put in the patient's sample. If it's got galactomannan, it actually gets sandwiched between that and another antibody that you add. And then you add a chromogen, and that will be picked up by the spectrophotometer. You can also see a change in color as well on the laboratory bench as well. So while it's mainly called Aspergillus galactomannan, it is positive in Fusarium, and it's often used in Brazil for that purposes. It can be also positive in Paecilomyces and Penicillium, but we don't see very much of those organisms here in Australia. So compared to hematology patients, it's very poor in serum. It's only got a sensitivity of about 30%, and it doesn't detect Aspergillus tracheobronchitis. In bronchoalveolar lavage fluid, it's probably better. It's got a sensitivity up to about 88%, particularly with the cutoff of greater than 1, sort of when you actually do the ratio as well. And it's of value, and there are some studies done by Shahid Hussain from Toronto, where they actually say that this can really differentiate from true colonization versus impending invasive disease. So if you remember from the slide, I said that galactomannan is released while hyphae are actually growing. So if it's positive, it means that it's not just fungus sitting around in the airways, it's actually fungus that's sitting around in the airways and getting active and starting to, I suppose, impending invasive disease. And if you use it in that manner, you can actually reduce the use of antifungals by 43%, and you can actually means that you don't miss any cases of invasive aspergillosis, or nobody progresses to invasive aspergillosis if you use such an approach. So that's why it's very important in the preemptive approach. PCR is being used. It's with a very limited assessment in the lung transplant population compared to the hematology population. There's been a number of commercially available assays which have been looked at, and its sensitivity is very good, but specificity is a little bit more limited, which is what you'd expect, because so you can have PCR in the airways, but what does it actually mean is the really important question. But it is more sensitive than culture, and in some areas it can actually be used in the setting of azole resistance as well. And of course, hyphae on histopathology, so if you get a biopsy, is very important as well. Then there's beta-1-D-glucan, which is a component of the cell wall of Aspergillus, Candida, and Fusarium. It's not present in Mucormycetes or Cryptococcus. And what happens is that if there's beta-D-glucan in the sample, it will activate clotting, and that can actually be detected by a chromogenic substrate or a turbidimetric assay as well. So How does that actually function? We do use it in the hematology population as well. It's been examined in lung transplant populations as well. And its sensitivity, when you use a cutoff of 108, which is, really, sort of a high cutoff, which really is discriminatory. It's only got a sensitivity of about 60%. It can't differentiate very well between invasive aspergillosis, tracheobronchitis, or colonization. And really, on its own, it probably shouldn't be used to actually make a diagnosis of invasive aspergillosis. It should be used in combination with other tests. It's very expensive, and I don't know of many centres in Australia who actually use it at all for anybody, regardless of whether they're lung transplants or not. So culture, sort of again, I talked about what does culture actually mean. You get a culture fairly readily, but you actually then have to figure out what is it actually doing within the airways as well. And you may well require invasive procedures as well to get cultures as well, such as transbronchial biopsies, EBUS, etc. So this is moving on to different diseases, etc. Tracheobronchitis or bronchial anastomotic mucosa, and this will be familiar to some people within the audience, but macroscopically, when they do the bronchoscope, they'll see the fungus on the anastomotic site. So it's fairly obvious, and we often get our lung transplant doctors ring us up and say, oh, the anastomotic site looks fungally, which is not very scientific, but it really is very descriptive to us. And the problems with this is it causes dehiscence and disseminated disease. And we recently had an experience of that with Lamentaspora prolificans in our institution. Usually you use systemic antifungals, but increasingly people are using inhaled antifungals, which makes sense because you're actually getting right to the site of the infection. And people using inhaled voriconazole. You can use the IV solution, or you can use the powder solution, which is now available on compassionate access. And then there's PC945, which is a drug which has been specifically manufactured to actually be inhaled and actually to gain high concentrations within the airways as well. And there are some studies undergoing with that, not in Australia as far as I know, but in the UK. So that's a useful tool that I think will come along in the future. And then the repeated bronchoscopy, careful bronchoscopy debridement is really important in this setting. They often go back to theatre for multiple bronchoscopies to actually just carefully chip away at the fungal infection to actually help with cure. So treatment of invasive aspergillosis, the first line is still voriconazole, and that's come from the Herbeck study in 2002, where there at least 25% of it were lung transplant population. Alternatives are posaconazole, isavuconazole. These have been studied in randomized control trials compared to voriconazole, and they're not non-inferior to those to voriconazole, but the number of lung transplants in those studies, well, isavuconazole, I couldn't find any when I looked at the patient population, and posaconazole, the more solid organ transplantation was a group of about 20%. How many of those were lung transplant? I couldn't find even in the supplementary data. Echinocandins can also be used as well, but they don't have great activity against many of the molds, and it's mostly fungistatic against aspergillus. So it's often only used in salvage therapy. And certainly I would never use it in isolation, given it's only fungistatic against aspergillus and has no activity against the other molds. It's good in combination. There has been a combination study done using an idursulfungin and azoles. Sort of as upfront therapy, it may not be the best thing, but certainly if you've got refractory disease or it's got severe disease at the outset, you might well use combination therapy of an echinocandin and an azole as well. Surgical debridement is very important, particularly if the lesion is close to the great vessels or there's a single lesion and it's not getting better. And also thinking about decreasing immunosuppression is very important. Just talking about Scedosporium and Lamentaspora, this is probably the second most common organism that we see here in Australia. It's very different in other countries. The Lamentaspora is really resistant to many of the antifungals agents, as you can see here. In fact, it's not to our standard currently available agents. It has have no activity against Lamentaspora prolificans. Voriconazole is quite good against Scedosporium apiospermum. The risk factors for it are pre-lung transplant colonization, previous receipt of amphotericin B, and augmented immunosuppression. So Peter and his group in Western Australia have looked at their population of lung transplantation populations between 2004 and 2017, and you use a hybrid sort of prophylaxis strategy that I won't go through, but it's present in the paper, and it's really nice. And in that population, 110 patients isolated a mold at least once post-transplant, and 134 respiratory samples were positive for a mold as well. So they calculated a rate of invasive fungal disease of 2.1 per 100 person years, and Scedosporium was the second most common cause of invasive fungal disease, with 2 cases. But the point really is that using a prophylactic strategy really does reduce the amount of invasive fungal disease you actually see. And then when you actually do see it, you can keep an eye on it with a preemptive approach. When you do actually see it, jump onto it very quickly, and all-cause mortality is very, very low. We looked at our lung transplant population at the Alfred. We went for a lot longer. We went back to 1995, and we found that 3.1% of 962 lung transplant patients in that period actually isolated either Scedosporium aviospermum or Lamentaspora prolificans, and 63% of those had invasive disease and 27 had colonization, and there was no difference in survival between them, either if they had a pre-transplant or post-transplant, compared to those who didn't actually isolate Scedosporium or aviospermum as well. But one of the most important things that we found was that it actually only happened after 2014, which is very interesting. And it really, we feel, is that there's probably some sort of fungal selection here or survival selection here, and as to why this is actually happening after 2014, because we're using other antifungal agents to prevent aspergillus or to treat aspergillus. They're surviving longer, and then they're actually makes them more exposed to actually getting Scedosporium. At least that's what our theory is, and the larger studies need to be done to actually prove that. I'll move on in the interest of time through those, and this is the treatment of sort of these agents, and particularly I want to draw your attention to Scedosporium, where we actually use voriconazole and terbinafine for Lamentaspora prolificans. That actually should say, apologies. So I wanted to really talk to Cryptococcus, because I do think that, so this is, sort of the third most common fungal agent that is isolated in many countries around the world. And it certainly is common in Australia, and as you will see going forward. It occurs in about 2% of lung transplantation patients, and the lungs are the most common site. Dissemination can occur, but it's much less frequent than it being in the lungs as well. And colonization it can occur, as can endobronchial lesion, but they're very, very rare. It's mostly actually invasive Cryptococcus within the lungs. There's a recent Australian study that Monica spearheaded, and there was 46 hospitals involved in this, 475 patients, and 90% of the patients were HIV negative. 81 had had a solid organ transplant, of which 17 had had a lung transplant. And the median time, which is long, which is sort of consistent with the international literature as well, it was 35 months from the transplant as well. And 16.4% were detected incidentally, sort of, which is good. Serum cryptococcal antigen was done in over 80% of patients, and those who had a high level, which is defined as greater than 320 or 256, depending on which assay you actually use. And that predicted the risk of CNS disease. Importantly, in patients who had asymptomatic disease, we generally, as guideline-based, do, if they've got asymptomatic disease, we generally still do a lumbar puncture to see if they've got CNS disease. But if they had asymptomatic disease in terms of CNS, the lumbar puncture is only positive in 13.2%. So we may well be able to use lack of symptoms and a high serum cryptococcal antigen to decide whether we do lumbar punctures or not, rather than what we do currently, where we do it at every single patient. So that's a very interesting finding from this study. But probably what's one of the most interesting things is that in the HIV negative population, cryptococcal disease has increased over the time as well, which is very interesting. And certainly the number of cases we've seen in the last few years would actually echo that as well. So is it primary disease? Is it donor-derived? Is it reactivated? I think this is important in terms of us trying to decide about cryptococcal antigens and whether we should do them in all patients, screening going into transplantation, or whether we should do them regularly as well. Nobody quite knows, and that's certainly some areas I think for research going forward. The risk factors are alemtuzumab and corticosteroids. And then if you have pre-transplant Cryptococcus, is it a contraindication? No, it's not, as long as the disease is controlled, and that you would continue fluconazole for about 12 months after the transplant as well. In terms of treatment, liposomal amphotericin B is used for induction with 5-FC, particularly if there's CNS disease. Consolidation is usually, and maintenance is usually an azole as well. And that's for neoformans, for Gattii. Sort of again, it's similar treatment, but sort of a disease that actually takes them longer to get control over C. Gattii compared to neoformans. And C. Gattii, it seems to be have a particular propensity for Australia rather than so any other countries as well. I'll skip over this a little bit, but I think it's really important for us to remember drug-drug interactions. They're really important in this population, and particularly when you use azoles, and particularly when you're on and off azoles, you've got to remember to dose adjust your tacrolimus as well. And patients often, get unstable as far as the tacrolimus levels are concerned, which may feed into, some of the issues with survival and graft function as well. And therapeutic drug monitoring, I'm a fan of therapeutic drug monitoring, and we do it systematically in all our populations at the Alfred, and we've looked at it in our solid organ transplantation patients, particularly our lung transplantation patients, and super therapeutic levels are rare. It's usually sub-therapeutic levels that we actually get, and it's really effective in eradicating colonization when you actually use it as well. And we also show that modified release tablets were very effective in getting therapeutic levels as well. So in summary, I think fungus with the lung transplant population, early diagnosis is critical, so you really need to think about it all the time. Fungicidal treatment is needed, least broad, at least initially, antifungal susceptibility drug levels as well. Debridement is often necessary. I think about lowering immunosuppression, and I think we need to remember that it's not just fever. It's not enough to make a diagnosis, nor is a physical examination. You need radiology and other investigations. And remember drug-drug interactions and drug toxicity. Thanks.
Thanks, Orla. Just one question. I apologise, all of you mentioned about azole resistance and aspergillus.
Yeah, I didn't mention.
Is that an issue or not?
It's not really a huge issue here in Australia, although so it's about 1 to 2%. More recently, there's a study being done, an aspergillus, national aspergillus study being done, which shows that it's probably a little bit higher, around 6-7%. So it's starting to perhaps creep up, but that Australian data isn't published yet. But it's interesting to note that it's going up, and we need to be careful.
Great. Thanks, Professor Morrissey. That's terrific.